Well, I'll introduce myself. I'm Louise Emmett. I'm a nuclear medicine physician from Sydney, and it's a great pleasure, and thank the organisers for asking me to talk today. It's an even greater pleasure to be talking on this subject, what to do in non-responding PSMA RLT patients. Because we're fantastic in Diagnostics at celebrating our successes, celebrating those exceptional responders with their beautiful images. But we do leave behind our failures a little bit, and about 50% of our patients have either primary treatment resistance or early treatment failure to radioligand therapy, and the question is, what can we do for what is really the majority of our patients? These are my disclosures. And so we've heard very nicely already that from biomarker studies in the large randomised trials, SUV mean greater than 10 and ctDNA fraction of less than 2% helps us identify exceptional responders. But if you have a ctDNA fraction of less than 2, or greater than 2%, or an SUV mean of less than 10, it doesn't mean you're not going to respond. So actually trying to figure out who you intensify up front is an extremely difficult question. My question is, can we intensify everyone so we don't have a 50% failure rate? Or people actually respond for longer? And that was a question asked by Scott Tagawa some time ago, where he did an excellent dose escalation study. So can increasing the dose actually help our responses? So Scott Tagawa, 56 men, escalated up to 22 gigabecquerels, and that was a fractionated dose day 1, day 15 of 11 gigabecquerels. At that top dose, despite no PSMA PET criteria for inclusion, he got a longer PSA progression-free survival than therapy, longer radiographic progression-free survival than therapy or vision, even though only 2 doses were administered. So it's really a key question. Are we giving a high enough dose in our patients? And giving higher doses up front, does that really improve outcomes in our patients? We really don't understand the biology of what we're doing to know whether we should be fractionating earlier, should we be shortening fractionation. In radiation oncology, they're doing 5 fractions. Instead of doing this long, slow treatment. Should we be doing a 5-fraction treatment with lutetium PSMA in order to get better responses? And this is some really compelling data preclinically here at Johan de Bono's lab, where they irradiated castrate-resistant cell lines with 3 to 12 gray external beam radiotherapy. And with that irradiation, they got significantly increased PSMA expression. So can we use radiation? Can we actually use lutetium PSMA itself to potentiate and increase our target so that we get increased dose to the cell itself? So this is a patient, a clinical patient. They had a day 1, 7.5 gigabecquerels, day 6, 7.5 gigabecquerels. And if you look at the increased expression, SUV max went from 12 to 62. So you can get this increased expression by using the lutetium PSMA itself, potentially. We need to evaluate this. We need to do a lot of work in how we're treating. So this is a slide from Amir Iravani, a prospective trial called the LPS Boost trial. They're about to start in patients with SUV mean less than 10. And they're going to do bam, bam, cycle 1, day 1, day 7, and then bam, bam, cycle 2, day 1, day 7. Is that going to improve outcomes in these patients who are not going to be exceptional responders on SUV mean? And then can we use non-toxic, effective, complementary agents to actually improve our depth of response? So ENZA-P was enzalutamide versus enzalutamide plus 2 or 4 doses of lutetium PSMA in the mCRPC space. And we had a 95%, 50% response rate, an 80%, 90% response rate in these patients. So really not too many people left behind, with an 8-month improvement in overall survival compared to an active comparator arm, enzalutamide in the mCRPC space. First-line enzalutamide, it's true, so a vanishing population, but it's looking very interesting for second-line ARPI in conjunction with lutetium PSMA as well in the VISION trial. So both of these arms got lutetium PSMA. The only difference was the ARPI that was added in 52% of the patients in VISION, and a 5.5-month improvement in overall survival in those patients. And then we should look at ARPI with other radioligand therapies too. So ARPI with radium-223 actually had a 7.5-month overall survival benefit with radium-223 with enzalutamide. So really compelling. Should we be adding ARPI to radioligand therapy to improve outcomes in the majority of our patients? When it comes to identifying radiation-resistant disease, it's really hard. The mechanisms of radiation resistance are very difficult, and perhaps the best way of identifying a responder is the first dose. How well do they respond to the first dose? And as Tom Hope said at the last APCCC, everyone deserves 2 doses, or perhaps he should have said almost everyone deserves 2 doses. But it is a way that we can identify radiation resistance and sensitivity. And we've used the SPECT image to look at whether there's a reduction in volume plus PSA, or whether there's an increase in volume or an increase in PSA to identify, just at 6 weeks, radiation-resistant or radiation-sensitive disease. When should we change treatment? So we can do on these Kaplan-Meier curves an increase in volume, increase PSA, decrease in volume, decrease in PSA, up, down, up, and we can actually stratify patients quite nicely. So increase PSA and SPECT-TTV just at 6 weeks shows us a 2.8-month progression-free survival compared to 9 months in those patients who have a response. This has also been looked at with Amir Iravani, another nice study showing that both increase in total tumour volume plus new lesions are important in identifying whether a patient is a progressor or a responder on PSMA, so SPECT imaging at 6 weeks. And then some really nice data, I know Andre is going to talk about this, but looking at the ctDNA fraction that is residual at 6 weeks is also a nice way of identifying progressors and responders with radioligand therapy. So can we use early response biomarkers to help guide what we're going to do in our patients? What would we do with these patients once we know that they're responding? I think it gives us a good window to know whether we use composite biomarkers, PSA, PSMA, SPECT, ctDNA. We know whether a patient's responding or not responding. What can we do? So we can consider changing the treatment, changing them to chemotherapy if they haven't had it before. We can consider adding cabazitaxel to the lutetium if they're a mixed responder and part of their phenotype is actually responding to the lutetium as well. We can consider intensifying in those radiation-resistant clones to an alpha, or we could just change to radium-223 if they're not a responder. And I think it's important to look at the patterns of progression that are important in determining the next best steps post-radioligand therapy. So looking at these, this is being evaluated very nicely by the prostate group with LUCAB, which is lutetium PSMA plus cabazitaxel combined. And I think those results will be coming out fairly shortly. Action trial, actinium 225 PSMA 617, a Novartis trial, dose escalation post-radioligand therapy with a couple of other arms as well, looking at getting a randomised phase 2 dose, and safety and efficacy will also be coming out soon. And Novartis have moved on with PSM action. So they're taking the ability to add actinium following lutetium into a randomised phase 3 trial to see if we can actually take those radiation-resistant clonal populations and get prolonged response in those patients. And then, of course, there's a whole lot of new things coming along, and I'm not going to talk about those, but lead-212 looks interesting. Radium, obviously, is another choice, and perhaps radium plus ARPI as well after radioligand therapy is not working. So take-home messages, screening biomarkers and nomograms identify patients likely to have an exceptional response, but I think they're less effective at identifying those patients who will not respond, and we really need to work on identifying those better. Dose intensification with an ARPI, with alphas, they're all potential options for improving treatment response and limiting the number of non-responders that we have. The response to the first dose using PSA, SPECT, and ctDNA may help identify radiation-resistant disease, and personalised intensification options based on biomarker patterns of progression may improve individual outcomes in non-responders. Thank you.